Hello, I'm Ta-Chen Peter Chang. I'm a pediatric glaucoma specialist, and the title of my talk is Lessons Learned from This Challenging Case, Glaucoma. Here are my financial disclosures. They do not pertain to the content of this presentation. The chief complaint was cataracts. The patient is a 4-month-old male born at 37 weeks with C-section and had perinatal jaundice. And around the age of 3 months, mother noticed nystagmus in both eyes, and through a series of referrals, the child came to my clinic. On review of systems, in addition to eye problems, he also has proteinuria and glycosuria, and hypotonia and overall developmental delay. I took the child for examination under anesthesia, and to my surprise, he actually had very elevated pressures in both eyes. He has mild corneal edema with pachymetry in the high 600s, low 700s, and on ultrasound B-scan, he had marked cupping in both eyes. And here you can see the external photograph. His cornea is not grossly enlarged. However, there is significant haze centrally. When congenital cataract presents with congenital glaucoma, the differential changes. High on my list is Lowe syndrome, followed by congenital rubella syndrome, and then certain types of uveitis conditions. My biggest concern will be uncontrolled inflammatory changes leading to ptysis in the surgical eye. So I had a long conversation with the parents, and the mutual agreement was to perform cataract surgery in the left eye only and come back another day to do the cataract surgery in the fellow eye if the first eye fared well. So we proceed with lensectomy in the left eye. Here's the video of the surgery, which was fairly challenging. As you can see, there's a fair amount of corneal haze, and the pupil did not dilate very well, so we're placing iris hooks for the desired pupillary dilation. The removal of the lens itself was fairly unremarkable. After cortical cleanup, as I always do in infants, I removed the posterior capsule and performed a fairly generous anterior vitrectomy to prevent opacification of the visual axis. Following removal of the iris hooks, we close our corneal wounds and meticulously close the conjunctival wounds to prevent any leakage. And here is his surgical log. You can see that on the first exam under anesthesia, he had elevated intraocular pressure in both eyes, and I suspected the normal readings in the clinic were falsely low due to corneal edema, and that was when we performed lensectomy of the left eye. When we performed the second exam under anesthesia, you can see that the left eye, which is now aphakic, actually has spontaneously normalized pressure, whereas the phakic right eye still had high pressure. So we went ahead and performed lensectomy in the right eye in the same manner as that of the left. And finally, on the third exam under anesthesia, both eyes had markedly improved pressure, but the right eye is still a little bit elevated. And this is what the optic discs look like. Previously, they were graded to be marked cupping on B-scan. These were more like moderate and mild cupping. And from the axial length graph below, you can see that the axial lengths in both eyes have recoiled following the lensectomy surgery. And the most recent follow-up in August, he had adequate fixation behavior, normal pressure with the use of timolol once daily on the right, and it was on that visit when genetics result confirmed Lowe syndrome with a pathogenic variant in the OCRL gene. So Lowe syndrome, also known as oculocerebrorenal syndrome, is a X-linked multisystemic disorder and is very rare, estimated to be 1 in 500,000. And it presents with the triad of congenital cataract, severe developmental delay, and renal tubular dysfunction. So what lessons have I learned? In congenital cataract, we always do a glaucoma workup to make sure there's no concurrent glaucoma. And any child with bilateral cataract, we always get genetic testing. And the priorities when facing both congenital cataract and congenital glaucoma, The first thing we want to do is establish a visual axis to prevent deep amblyopia, followed by meticulous pressure control. Then we address any residual inflammatory issues. Thank you very much.